Amrita Sethi here. I want to thank the directors and the amazing women of AWE for inviting me again to participate in this year's course. Sorry, I can't be there with you in person, but really, really excited to see the success of this course. So today I'll talk to you about endoscopic myotomy, the other letters of the alphabet, so no esophageal, but rather some of the other interesting things that have come from our work with esophageal poem. These are my disclosures. So we're talking about peroral endoscopic myotomy, and what's been fascinating to see over the years is how many diseases or problems we can actually solve using the same technique. And this has become a bit of an alphabet soup, starting all the way up from the cricopharyngeus down to the Zenkers, esophageal. We'll talk about poetry, diverticular poems, STER procedures, gastric poems, and then finally ending and rounding it all up is prorectal endoscopic myotomy. So where does it all come from? Of course, from poem, which has a very standard technique with 4 critical steps. That's what we talk to our patients about. The first step being the mucosotomy, the second step being the tunneling procedure from the mucosotomy site all the way down to your target endpoint. So if for esophagus, it's the cardia, but for others, it's a different endpoint. The myotomy being the third step, and then finally the fourth, and usually the most critical step, is the closure itself. So I'm going to skip esophageal poem because either you've heard another talk and go straight to our other poems, such as cricopharyngeus, which you can see here. The cricopharyngeus is a bar up at the UES. And here you've seen incisions been made. And here it's a little bit different in terms of the tunnel is very, very short, just beyond the cricopharyngeal bar itself. And then oftentimes we have to apply myotomies for the third step using different instruments than what we typically use because of the limited amount of space that we have to actually manipulate the scope. So as you can see in this video, first spray coag with a triangular tip nose knife was used, and now scissor type knives, such as clutch cutters, for example, are used to really be able to specifically target that tissue. In a multi-center study of 27 patients, there was clinical success in 100% of them as measured by dysphagia scores, 100% technical success. The adverse event rate was only 7.4%, i.e. 2 patients, and recurrence only occurred in 1 patient. So a very effective method for a very unusual problem. And here you can see the radiographical improvement that you can see. This is what a cricopharyngeal bar looks like on an esophagram, this very pronounced indentation here. And here you see resolution of the indentation post C poem. The next we'll talk about is Zenker's diverticulum. So we're moving kind of from mouth to anus, not necessarily in terms of like what's most common outside of esophageal poem. I would say Zenker's and gastric would be the most common outside of that. So Zenker's diverticulum, as you may know, is when there is increased intraluminal pressure with simultaneous weakness in the posterior hypopharynx or the Killian's triangle that causes an outpouching. And when it's a lateral outpouching, it's known as a Killian-Jamieson diverticulum, and posteriorly is a Zenker's diverticulum. The main difference between the two is that you do have to worry about the recurrent laryngeal nerve when you're dealing with a Killian-Jamieson diverticulum, which is why some of the more standard therapies that we see with Zenker's can be somewhat risky. That's overcome by the Z-poem technique. Again, this is a rare problem to deal with, 0.01 to 0.11 incidence in the US, most commonly occurring in men, and that too becoming symptomatic and apparent in the 7th to 8th decade. Symptoms do include dysphagia, aspiration, cough, regurgitation, halitosis can be a common symptom, and ultimately weight loss. And there have been very classic techniques for Zenker's diverticulum, to treat Zenker's diverticulum, including just a flexible endoscopic septotomy, which is where we just literally cut across the septum. And now more specific techniques involving third space, such as a Z-poem, in which we are either performing a mucosotomy above the septum and dissecting out along both sides of the septum, and very specifically cutting the muscular wall of the septum and leaving the mucosa intact, or performing the incision along the ridge of the septum. So here's a Z-poem. You see that we first define the diverticular side and the esophageal side. In this case, we make a septotomy along the ridge and then dissect out the submucosa from both the esophageal side of the septum as well as the diverticular side. Once that has been achieved, you can then go ahead and cut the actual specific muscle fibers of the septum itself. The benefit of performing the Z-poem technique is that you can actually extend your myotomy beyond the level of the septum itself, because ultimately you'll be closing the defect exactly in the way of an esophageal poem and protecting from complications such as mediastinitis. The theory is that this allows for a more complete myotomy, as opposed to needing to spare some fibers in order to prevent perforation and complications such as just mentioned, although the data has yet to be determined. In this study, Ashima Alkaloy, 24 patients with a mean diverticular size of 4 centimeters were treated with 100% technical success and 96% clinical success rate, with not a significant procedure time compared to other poem procedures. How does this compare to our classical methods, such as flexible endoscopic septotomy? In this prospective randomized study, there were 13 patients that underwent Z-poem and 15 that underwent the traditional technique with similar size diverticulum. And you can see no significant differences in the procedure time. The technical success was 100% in both groups. And the clinical success was actually similar as well, with no clinical significance between the two groups. So really equivalent techniques, and ultimately what comes down to expertise. In some interesting study actually done by the Italian group out of Humanitas, they actually tried to try to determine or create an algorithm for which patients should undergo POES versus which should undergo Z-poem versus perhaps flexible endoscopic septotomy, and broke it down into those that had a naive diverticulum in which nothing had been previously tried and there was no scar tissue. In those cases, if it was naive, patients could undergo a third space procedure if the septum was less than 2 centimeters. However, if they had either undergone something, in which case scar tissue is available, or they were large diverticular, then these patients were recommended to undergo flexible endoscopic septotomy, with the thinking that leaving the intact mucosa would actually result in residual symptoms. In addition, this group also looked at kind of changing the site of the mucosotomy and performing the mucosotomy along the ridge of the septum itself. And in 20 patients that were treated with this method, they had excellent clinical success, no adverse events, had a mean procedure time of under 15 minutes, and also were able to discharge patients home the same day. Other techniques that are emerging in Z-poem, again, looking and comparing, does the site of the mucosotomy matter, whether it's above the septum or more proximal to the septum, allowing for a septal flap, or over the septum itself. And again, supporting the data that we just looked at, higher technical success and lower adverse event rates with the POES procedure, that is the mucosotomy along the septum, as well as shorter procedure times. And then Ken Binmuller, in his quest to make everything underwater, has looked at underwater Z-poem, in which 31 patients were treated, including those who had had prior treatment, up to 1/3. with technical success rates of 100% and no adverse events. So definitely emerging techniques, again, all with the basic foundation in poem technique, with some variation with the different anatomical locations. Similarly, when we look at diverticular poems, these usually are diverticula that are either mid-esophagus or epiphrenic diverticulum, just proximal to the LES. And these can really vary in size, but you can see here how sometimes the diverticulum itself is larger than the lumen of the esophagus. And there's some, question of whether these form because there's some degree of LES hypertension that causes, again, an outpouching of the distal esophagus. But nonetheless, this has been treated with poem procedure itself. Again, the mucosal incision is made proximal to the septum of the diverticulum. The submucosa is dissected out on the diverticular side, as well as the esophageal side, and then the septum itself is cut. And ultimately, the mucosal incision is closed. And here you can see a very pronounced septum, and then post-poem, 5 months later, a flattening of that septum and obliteration of the diverticulum itself. Certainly not an indentation or a resumption of the natural lumen of the esophagus, but the resistance is decreased because there is no muscular component left. And you can see the corresponding esophagram changes with that. So series have really lumped diverticula together, so including things like Zenkers, but overall show 100% clinical success with D poem, particularly for epiphrenic diverticulum. And when looking at subclassifications of Zenkers versus non versus mixed, have found no differences in technical success, clinical success, or adverse events. And there was an interesting study that actually looked at whether or not we need to perform a cardiomyotomy, that is myotomy of the LES, in conjunction with the septotomy of an epiphrenic diverticulum, for example, and found that endoflip might actually be helpful in this situation to show that if there is increased pressure, either measured by a high resolution manometry or endoflip, that those patients do benefit from performing a cardiomyotomy along with the septotomy. So even in patients who had a normal IRP, but who had decreased distensibility with endoflip, if they underwent a cardiomyotomy, they had significant improvement in their dysphagia scores when both were combined. And anecdotally, from my own experience with diverticular poem, I have found that patients receive the most relief when you perform a myotomy of the LES along with the septotomy. So let's continue down the lumen, if you will, and talk about gastroparesis and G poem. So gastroparesis is when defined as delayed gastric emptying in the absence of mechanical obstruction, and it's measured by gastric emptying scans, in which case there should be greater than 10% gastric retention at 4 hours. Etiologies include diabetic, poorly controlled diabetes, idiopathic, post-surgical, most commonly, for example, esophagectomies, and drug-related. And then symptoms are classified or clumped together into nausea, vomiting, early satiety and fullness, or bloating and distension, and these are measured by the GCSI or gastric cardinal symptom index score. And traditional treatments have included medications such as motility agents, pyloric interventions such as dilation with balloon, Botox, and even stenting, as well as placement of gastric electric stimulators, and then finally surgical pyloromyotomy. So GPOM offers an excellent alternative. Again, the same 4 steps are observed with GPOM, but with slight modification because of the anatomical location. So, for example, the injection and mucosotomy is performed not more than 5 centimeters from the pylorus. The mucosotomy is most commonly performed in a transverse fashion, although this for me is the same as an esophageal poem, but for many people who do longitudinal, this is a slight difference. And then the landmarks are very different as well. It's a very clear pyloric ring that you see in a G poem, where you see this crescent. This is along the greater curvature. You see sort of the happy face crescent with a wave of duodenal submucosa rising behind it, as opposed to esophageal poem, where the landmarks can be a little bit fuzzy. There are some distinct features, but usually not as clear as in a gastric poem. And then the myotomy is much shorter than an esophageal poem. It's not more than 3 centimeters, really just cutting the pylorus itself. It can be tempting to cut part of the gastric continue to extend proximally along the gastric wall. However, this is not necessarily meant to be effective. And the myotomy now, also variations are being done where there can be a double myotomy with removal of the intervening muscle with the snare. And then finally, closure does varies depending on the endoscopist, but suturing does offer a very robust closure here, as well as an easy way to deal with a transverse incision. So how does it perform? Well, in this more recent meta-analysis, you can see that the size of the studies were kind of very varied, but overall, the clinical success ranged from 66% to 100% as measured by gastric emptying times, as well as symptom index scores and improvements. The adverse events were rare, not more than 1 to 2 per study, and most often included things like capnoperitoneum or bleeding or death not related to the procedure, but not with not great follow-up time. We finally did have a very important prospective study, sham-controlled study, out of a single center from Europe, in which 20 patients underwent GPOM versus 20 that underwent sham and had 6 months follow-up. Those who underwent sham, who had no improvement, were actually crossed over to the GPOM group, and treatment success was seen again, as measured by symptoms and gastric emptying scan and 71% who underwent GPOM compared to 22% who underwent sham. And then for those who crossed over to the GPOM group from the sham group, actually 75% of those patients actually had symptomatic improvement. This was so striking and significant that the study was actually stopped due to the poor response in the sham group. Predictors of clinical success included a male gender, a baseline symptom index score of less than 2.6, gastric retention on scans greater than 20%, and when endoflip was used, a post-poem sensibility index of greater than 13, with variable data on what the baseline pre-index was. The study was not powered to look at the differences in etiology, but did find that the highest rate of response was with when it was diabetes-related gastroparesis. Just to look at some other comparative studies of how GPOM performs compared to other treatment options. One study that looked at GPOM versus the electric stimulator for refractory gastroparesis found that there was a greater response with GPOM, particularly for those patients who had idiopathic gastroparesis. And compared to surgical pyloroplasty, there was no significant differences in the outcomes. There was an interesting point that came out of this study that looked at whether or not, or questioned whether or not, a response to Botox could be considered as a predictor, and found that the actual response wasn't a predictor, but if patients underwent Botox, regardless of whether they responded or not, so Botox plus dilation, they had a more favorable outcome compared to those who had not received Botox prior to GPOM. So whether this makes a difference in how we treat these patients is unclear. I can say, again, from my own practice in working with my motility colleagues, that we often have an approach of offering patients Botox to start. And if they have a favorable response to Botox, we actually recommend moving on to GPOM rather quickly, within 1 to 2 months, and have had very reasonable results. Another study that looked at predictors of success was actually this multi-center prospective study out of Europe that followed 46 patients for 3 years and found that overall the clinical success was 65%. And they tried to come up with their own scoring system to predict success. So they used the categories of the GCSI, including the nausea category, the satiety category, and bloating, and provided a point for, as you can see, depending on the number of symptoms for each subcategory, and found that a score of 2 or greater predicted responders at 3 years with an area under the curve of 0.825 or 80% compared to those who had scores of less than 2, which was 18%, which was significantly different. And so this suggested a possible tool to help choose patients that might have better response, although this needs to be validated. And then, of course, there's always modifications that are being made. We don't yet know if these make differences, but these do include things like performing a double myotomy along the pylorus itself, or performing a lesser curve, the poem along the lesser curve. So here we go along the lesser curve. It's actually a shorter tunnel. And in this case, it's almost no tunnel. And here you see the crescent. It's going to be more of a frown, or an because it's downward facing, and the submucosa will be inferior to the pylorus, but again, very, very evident compared to the esophagus, very distinct. And then the myotomy itself, again, will be fairly short. You can see just not more than about 2 centimeters, and then closure will again be of endoscopist choosing, but in my experience, the suturing works quite well and is quite robust, and we can send these patients home on the same day because of security of knowing that these mucosotomies are closed. So finally, all the way at the end of the GI tract, we have the rectum, and rectal endoscopic myotomy, or PREM, has been really championed by Amol Bapaya out of Pune, India, that first used it for a patient with Hirschsprung's disease. And you have significant improvement in the motility of these patients using exactly the same techniques. It's just a reverse approach in terms of the direction that you go for the myotomy. And this group has continued to do cases with excellent success following the procedure. And then basically with POEM, we have the concept of tunneling. So other procedures such as poetry, P-O-E-T-R-E, have been described, in which case we're really creating a new lumen. So in this case of complete esophageal occlusion, Peter Darganoff's team described tunneling proximal to the occlusion to create a neolumen, and then rendezvousing with a scope that went through the PEG site, and then finally placing a stent again to create a new esophageal lumen. So taking that concept of tunneling to another level, instead of performing myotomy, and using it for access to submucosal tumors. We have 2 main ways to deal with submucosal tumors in terms of endoscopic resection. One is the STER procedure, submucosal tunneling endoscopic resection, and the other is what we call full thickness resection, where typically in an ESD fashion, we are going to resect and then close whatever defect we create. In addition, in terms of full thickness, there's the close and then resect, which is a dedicated device, which we're not going to discuss here. So indications for this type of full thickness resection do include symptomatic submucosal tumors, GISTs that are greater than 2 centimeters, but usually less than 4 centimeters, or have some high-risk features by EUS. Neuroendocrine tumors can be treated this way. And then in terms of full thickness, there are other indications such as adenomas with scarring. And lesions that we're looking for treating in this manner also do include those that are in locations in which surgery might be difficult, such as the cardia or proximal to the GE junction, which might require more extensive surgery just due to the location, such as a total gastrectomy. And so in this way, we can spare the lumen. So for the STER procedure, or the non-exposed EFTR, we're basically going to create a tunnel until meeting the tumor. So it's providing access to the tumor, dissecting out the tumor from the surrounding mucosa, and then whatever structure within which it's lying or originating. So if it's the muscularis propria, or sometimes even externally, finally closing the mucosotomy site, much in the fashion of poem. So here we have a submucosal lesion just distal to the GE junction. Would have been a little bit of a complex surgical procedure, so we were asked to deal with this endoscopically, so creating a tunnel about 5 centimeters proximal to the lesion in the esophagus, much in the fashion of poem. Here we can see the capsule of the tumor, that's very typical white appearance, and actually dissect this out from the surrounding submucosal fibers. As with poem, we want to really protect the mucosa. In this particular case, the mucosa did get injured, and we ended up using that to our advantage by using that as an exit site for the tumor from the tunnel. This has actually now more recently been described for larger tumors that can't quite be pulled out of the tunnel because of the limited size of the tunnel. But in general, the goal is to extract the tumor from the tunnel itself and then merely close the mucosotomy site. In this case, any mucosal defect was closed with suturing, and this patient did quite well and was able to go home the next day. So a recent meta-analysis looked at a number of studies, again, relatively, usually sort of smaller studies. There was one that reached over 700 patients, and with the location most commonly in the esophagus and GE junction and the proximal stomach. Here you see endoscopic en bloc resection rates as high as 97.5%. Complete resection rates of 100%, and adverse event rates of up to 21%. The recurrence was 0, and here you see the various histopathologies. This is just to show you what the comparison is. A pure exposed EFTR is when ESD is performed. The overlying submucosa may, in some cases, be unroofed, followed by dissection of the lesion out. And if this is arising from the muscular propria or even from external to that, then the muscular propria has to be breached, which results in a full thickness defect, which is eventually closed. And then on the next frontier has been reached with fourth space endoscopy, STER with extra luminal tumors. So in this animation, it describes basically, again, using the tunnel as an access point to reach the point where the tumor is located outside and pulling it through. This has primarily been performed by the Chinese group out of Shanghai, and they describe excellent success rates in a limited number of patients. Smaller lesions, again, less than 4 centimeters, with very low adverse event rates. Obviously, it does require a high level of expertise if we compare this to surgery, there's differing results. In one study comparing EFTR to laparoscopic surgery for just less than 2 centimeters, there were decreased complication rates with EFTR. And in another, there were decreased operating times with the laparoscopic group. In a study looking at STER specifically versus thoracoscopic enucleation, there were shorter operating times, post-operative stay, hospitalization costs, and blood loss in the STER group. And then in a recent comparative study, prospective, EFTR was compared to STER. So the exposed technique was compared to the tunneling technique specifically for GIST. 26 patients in the EFTR group and 20 in the STER group. And there was earlier resumption of diet and a shorter hospital stay with the STER group, but a higher en-bloc resection with the EFTR group compared to the STER group. Decompression as during the procedure was needed more often, however, with the exposed group, as we would probably expect, because we are, obviously trying to make a defect in the wall and complete the resection prior to closing it. So in summary, POEM as a technique is a game-changing procedure that can be adopted anywhere along the GI tract, as long as we adhere to the fundamental steps. CPOEM is feasible, effective, but technically more challenging because of its location. And diverticular POEM does work for all types of esophageal diverticula with good technical and clinical success. GPOEM has good technical success, but has moderate clinical success, and oftentimes patient selection is the key to success for these patients. And finally, STER is a safe, effective method for resection of subepithelial tumors, particularly those less than 4 centimeters. Although it should be noted that exposed resection is associated with higher en-bloc resection rates. So I thank you again for this invitation, allowing me to be part of your conference, and I wish you best success with the rest of it. Thanks so much.